Assalamualaikum warahmatullahi wabarakatuh and a very good afternoon. I'm Dr. Nadia and it's a pleasure actually to see you, all of you here. First, I would like to thank the committee members for inviting me to give a talk. The topic given is endocrine surgery as a treatment for cancer. I can see few of the surgeons here from other subspecialty. I will try to make this a brief overview on the surgical point of view. Okay. So, what is endocrine surgery in treating cancer? Endocrine cancer surgeries are often part of a multidisciplinary approach to treatment. Apart from chemotherapy, radiation therapy, hormone therapy, and targeted therapy. Okay, but surgery still remains the primary treatment for certain localized endocrine cancers. So endocrine surgery is a specialized field that are indicated in endocrine cancer of the thyroid gland, parathyroid gland, adrenal gland, and neuroendocrine tumors of the pituitary, pancreatic, and gastrointestinal tract system. So this is the commonest slide that we have seen for the past few days. According to the Malaysia National Cancer Registry, until 2016, the most common cancers in Malaysia, the top 10 definitely is breast cancer, followed by colorectal cancer. But here you can see that endocrine tumors is not listed there. But moving on to the 10 most common cancers by sex, you can see again in male patient, there is no endocrine cancers listed. But in female, it's actually thyroid being the 8th commonest cancer in females. The endocrine surgery for cancers, basically for the thyroid gland, for well-differentiated thyroid carcinoma, which is include the papillary, the follicular, and also for medullary thyroid carcinoma. Anaplastic thyroid carcinoma, which is the undifferentiated thyroid carcinoma, very limited, but some patient may present it early. And if it is actually a stage 1 and resectable, probably the surgeon will remove that. And also parathyroid cancer and adrenal cancer. So adrenal cancer, the commonest one is known as adrenocortical carcinoma, and also for malignant pheochromocytomas and paragangliomas. So adrenal cancer is basically, it can be either functioning or non-functioning, depends on the secretion of the hormones. What are the goals of surgery in endocrine cancer? Basically, it depends on the intent. Okay, either it's a curative or palliative intent. In general, the surgery should improve the overall and disease-specific survival, and it reduces the risk of persistent or recurrent disease. It should permit the accurate disease staging and risk stratification, but with the minimum morbidity and, if possible, prevention of further unnecessary therapy. Again, the surgery should be performed depends on either it's for curative or palliative, and the indication between these actually depends on the various factors. Okay, either the patient's factor, which include the age of the patient, the morbidity, the ECOG performance status, and also the treatment goals, and the disease factor, which are the type of the cancer and the stage of cancer. Either it's a local disease, locally advanced, or is it actually a stage 4 metastatic disease. Okay, we move on to a few of pictures here. So you can see here is actually a pretty straightforward case. A female patient presented with left thyroid swelling. Okay, and then the preoperative imaging actually showing a huge left thyroid nodule cancer, but with a normal contralateral right thyroid. But this patient actually has a compressive, it's not compressive, but it actually pushed the trachea, which is supposed to be in the midline, to the other side, and also the vessels there, the IJV and also the carotid. Sorry, it can be moved. Okay. The next slide, this is a male patient. You can see presented with a right thyroid nodule, a huge thyroid tumor. And the preoperative chest x-ray actually showing a huge right thyroid with deviation of the trachea to the contralateral side. It's not only deviate, it push away the trachea to the contralateral side, it also cause narrowing. Okay, besides that, actually this patient has a significant retrosternal extension there. It's about 50% of the thyroid actually are within the mediastinum. Okay. In this case, this is a male patient presented with neck swelling too. But it's not that really huge from the outer part, but something is not right with this patient. And then the imaging actually showing that a huge thyroid carcinoma, you can see it actually, again, more than 50% of the thyroid actually extend or located within the mediastinum. So in this case, if actually this patient is for curative resection, this is not a simple surgery. Definitely, we will invite our cardiothoracic surgeon to, if this is for a clear resection of the thyroid cancer, to open the chest. We move on to the evolution in endocrine surgery. The advancement in imaging techniques and modalities have revolutionized preoperative planning for endocrine surgeries. Subsequently, it minimized the risk of complications, and more precise and minimally invasive surgical techniques has developed. Conventionally, we used to do laparotomy, open midline surgery, but now, depends on the cases, we move towards a keyhole or laparoscopic and also robotic assisted surgery, which this keyhole surgery, minimally invasive surgery, it offers benefits such as reduced morbidity, faster recovery, and improve the cosmetic outcomes. And over the years of constant refinement of surgical techniques, okay, for the good impact, better outcome, and the quality of life of the patients, there are a lot of updates. The recent updates recommended that thyroid lobectomy is actually doable, recommended for low risk, well-differentiated thyroid carcinoma of papillary thyroid carcinoma, papillary microcarcinoma, and minimally invasive follicular thyroid carcinoma. As I mentioned earlier, the involvement of the technique of the surgery of laparoscopic, it is actually recommended for retroperitoneoscopic laparoscopic adrenalectomy, and again, some actually, especially other countries, have developed on robotic adrenalectomy. What are the challenges in endocrine surgery in treating cancers? It varies. It depends on the patient's factors, again, the age of the patient, the comorbidities, the performance status, and also the disease factor, what type of cancer, and what stage or the extent of the cancer. Again, that you can see here, this is a pretty straightforward case, young patient with a solitary left thyroid nodule in comparison to this gentleman who has significant dilated neck and chest veins. Okay, so this patient actually ventilated and sedated because he's diseased, and actually the prominent vessels here indicate that the extension of the thyroid cancer are actually within the mediastinum, which cause the SVC obstruction. Again, this is different patients. The tumor, the thyroid cancer, it can be compressive and infiltrative. You can see here is a huge thyroid, which more than 50% actually are within the mediastinum. It caused the trachea to be deviated to the other side. And this one, the left thyroid cancer is not so huge compared to this one, but you can see it actually invade the tracheal ring. Okay, so this is actually a locally advanced thyroid cancer, and when actually the film showed like this, definitely the recurrent laryngeal nerve, which is important for the vocal cord and the production of voice, is at risk. What about this one? The CT scan showing retrosternal extension again. And again, this one is, we have to invite a cardiothoracic surgeon to go in to achieve a curative resection. This is another example of left thyroid cancer, which is huge. It is actually compressed, okay? It compresses the trachea and it deviates the trachea from the anatomical plane. But this is also a nightmare for surgeons, because of the tumor actually encased. You can see a carotid artery here, which is surrounded by the tumor. So if you want to achieve a curative resection is basically you need to get a negative resection margin. So definitely this one have to have to combine with vascular surgeon, because it need to get a proximal and distal control of the vessels to avoid brain ischemia, stroke, and so on. You can see here also the IJV, internal jugular vein, is also obliterated. So these are among the difficulties that we encounter in some cases. What about adrenal cancer? Adrenal cancer, 60% of the adrenal cancer can be functioning, either is functioning or non-functioning according to the secretion of the hormones. So 60% are actually Cushing. So this patient has a typical presentation of Cushing, where she has a significant moon face with buffalo hump and also a florid acne, and she has truncal obesity with abdominal striae. It can also occur in male patients with similar presentation of Cushing's. Also SCC, adrenocortical carcinoma, can presented with this. We have a patient, a young patient, 30-year-old, medical officer, doesn't have any significant medical illness, but she presented, she is a runner, okay, of long marathon, and then she presented with virilization. So it is actually a characteristic of male in her case, where she has mustache and also the beard, and she keeps winning all the trophy for the past 2 years, very energetic. Then when she did a biochemical screening, it is actually confirmed she has this functioning sex hormone, adrenal SCC, and then luckily it was a stage 3 disease, meaning the tumor it has involved the spleen. So this is no choice. We have to do a open surgery for her, and then successfully remove the tumor, the whole tumor together with the spleen. Thank you. This is another example of, because of the evolution in endocrine cancer. Okay. Some of the surgeons have moved towards RPE, retroperitoneoscopic adrenalectomy. Okay, but this is again depends on what, very selective, the patient, the criteria of the tumor. So because traditionally we used to do all open surgery, so that require a long, either midline incision or actually a posterior long incision. So with this technique, only require 3 small incision, and then the approach is from the back. In this case, this is a right adrenal gland, adrenal tumor, which is measuring about 6 by 7 centimeter. We managed to remove that without crushing the specimen, but we have to extend the one of the incision is slightly larger to remove the specimen. This is for the left. This is another patient, different patient, of the removal of the left adrenal. In this case, you can see it is actually, again, this is a combination. Treating cancer is always MDT. Okay, so in this case, we have to do open approach for removal of this adrenal cancer, but combined with vascular surgeon, because there is actually a tumor thrombus within the inferior vena cava. All right. Okay, we move on to palliative adrenalectomy. So is there any role of palliative adrenalectomy, or what we call as debulking surgery or metastatectomy? Yes, it is, but again for selected patients. With the benefits aim to improve the quality of life and disease control, especially in the high tumor load. Like in this case, we have a 52-year-old lady with ACC, which is diagnosed as a stage 4 disease. However, she's highly symptomatic on mitotin and other combination of chemotherapies. Then MDT has decided this patient may benefit from debulking surgery, and then we proceed with that debulking surgery, whatever that can be removed. Luckily, it was uneventful, and she had actually improvement in psychophysical symptoms, and the doses of the drugs managed to be reduced. And actually, she had a 3 months, prolonged survival. This is the last case that I will share today. This is a 32-year-old with diffuse large B-cell lymphoma, which was diagnosed in 2012. So she had a complete remission 9 years after CHOP treatment, but she had a left neck swelling for the past 2 years with symptomatic dyspnea and dysphagia. Clinically, it was a large left thyroid nodule. Clinically, she was euthyroid, and biochemistry confirmed that she actually euthyroid. Ultrasound showing TRADS3 and ultrasound guided FNA showing FLUS, follicular lesion of undetermined significance, means the risk of cancer is about 5 to 10%, and the preoperative IDL was normal. This is the preoperative CT scan for her. Again, the tumor on the left side with a normal right thyroid lobe. There is a component of substernal there, but she underwent a left hemithyroidectomy with continuous intraoperative nerve monitoring. It was uneventful surgery, and this is actually the tumor of the left thyroid removed completely. Unfortunately, the HPE comes back as a follicular thyroid carcinoma with vascular invasion. Then, meaning this is a high-risk, well-differentiated thyroid carcinoma, so she had to complete with the total thyroidectomy. This is my concluded slide. A multidisciplinary approach is a wisely advised for a better care of the patient, and a personalized treatment, which is a specific treatment plan, should be tailored to the patient's need and disease factors based on the intent of the treatment for the better outcomes and overall survival. With that, I thank you for your patience.
Thank you, Dr. Nurul Nadia, for the astute presentation. We open for Q&A. Yes, Doctor.
Hi, Doctor. Thank you so much for your sharing. My question is for myself. I'm a NET patient. I just diagnosed with neuroendocrine tumor last September. So now we are actually dealing with the liver mets, and the therapy is more of a symptomatic therapy. So my question will be, what are the chances if I were to do surgery on the liver to reduce the needs of a long-term therapy towards my symptom control? I'm not quite sure how should I put this question to you, because actually we haven't found the primary lesion yet. We are still dealing with the liver mets, but maybe I want to know about your opinion about surgery of the liver, so that I don't have to, it gives me hopes that I don't have to go to the long-term treatment for the symptom therapy, because now I am just on the symptomatic therapy treatments. I'm not sure whether is it something?
Okay. First of all, thank you for the questions. First of all, this is quite private, correct?
Yeah.
What is your NET tumor is actually the primary is the liver?
No, liver is the mets. My condition is neuroendocrine tumor with liver metastasis.
I may not be an expert in these NET tumors. Okay, I'm a consultant of general breast and endocrine surgeon, but the principle here is actually when you are diagnosed with a neuroendocrine tumors, of course it is challenging, correct? Again, it will require MDT, but first of all, we have to find out where is the source of the NET. Because when you are diagnosed, now it is actually a stage 4 disease, is it?
Yes.
Okay, with liver mets. And then first, by right, we have to find the etiology, because different organ have different prognosis and different kind of treatment. Let's say even for NET of the GIT, it's best to resect first, then followed by the multimodality adjuvant treatment. So I think in your case, the primary is still not known, but when it is
they are suspecting of to be in the small intestine, but they say that if you were to find even in the small intestine, surgery is not something that we want to go about. So coming here today, I just want to enlighten myself and really understand things on my terms. Because every time I go, it's on their terms.
Okay.
I hope I get it right.
You can meet me afterwards, okay? But in general, we will have to find out, because the treatment is different. But in general, for NET tumors, you must find what's the etiology of the tumor. Now it's actually a stage 4 disease, so it may not it may not change much the role of surgery here. But even TKI, when you talk about targeted therapy, they have different pathways to be targeted at. So I would believe, because the problem with NET, neuroendocrine tumors, is the symptoms, the secretion of the hormones. So for I would say probably doctors, your treating doctors actually because it's a stage 4 disease, so they are trying their best to at least control the symptoms of NETs by giving you whatever treatment now. But I believe sometimes, even though it's a stage 4 disease, but because we have the evolution of the multiple adjuvant targeted therapies, so Dr. Jenny also can probably give an idea on that, but I would say we have to go through in detail about that. But now is actually they are for your improvement of the quality of life by giving you that treatment. Dr. Jenny, probably.
If I can add, thank you for sharing your case with us. So for neuroendocrine tumors, about maybe 10 to 15%. You may not be able to find a primary from the onset, but often it's the liver mets. So we're thinking the likely primary would be usually small bowel or small intestine or pancreas. So it's important to know what is the grade of the neuroendocrine tumors. And if it's a grade 3, usually we may ask the patient to go for chemo. But again, it's personalized medicine. So if it's a grade 1 or grade 2 neuroendocrine, we often ask the patient to do a PET scan, but it's a gallium PET scan. So as just now Dr. Mawinder mentioned, there's different type. A gallium scan will let you see what is the octreotide receptor. So if it's heavy disease, the current standard of care is actually PRRT. So it's a peptide radionuclide ligand. So they inject actually the gallium radioactivity, and I have patients who have extensive metastatic disease in the liver. After 4 years, she is still well. So it's actually targeting the right treatment to the liver mets. So one of the things you perhaps would like to ask would be if you've done a gallium scan, if you are not that very symptomatic, your liver function is preserved, then usually they'll offer octreotide alone for symptom control. But come to a point where we think that the metastatic disease is getting more, then speak to your doctor maybe about PRRT. It's also available in, I believe, Institute Cancer Negara. So it's a treatment that is injection over half an hour, and usually it's repeated maybe few months down the road. And also looked at your serum chromogranin A. That is the tumor marker that will let you know your tumor burden. But generally, neuroendocrine disease has very good prognosis. Yeah, so you're welcome.
Thank you, Dr. Nurul Nadia and Dr. Jennifer. Due to time constraints, we are closing the Q&A, but you can approach the presenter later during the coffee break. Thank you.